So priority examples for education include providing sepsis-specific training or education during the onboarding process for staff and trainees. So for people who are new to working at your hospital or healthcare system. We also recommend having annual sepsis education for all clinical staff and having a mechanism to provide written and or verbal sepsis education to patients, families, and or caregivers prior to hospital discharge. Next slide. In terms of existing additional examples of education, include posting information on sepsis recognition in prominent areas for patients-facing staff, such as on the machines that are used to collect vital signs or in staff break rooms, providing annual lectures, such as grand rounds focused on sepsis, and then including sepsis recognition and treatment in annual nursing competencies.
Today, we're going to go ahead and take you on a journey on how we provide sepsis education and the multiple modalities that we use to reinforce that education to facilitate prompt recognition of sepsis through positive patient outcomes. So to give you a little bit of a background on our facility, we are a level 1 trauma center. We are a safety net county hospital. We do medical trauma as well as we are the psychiatric emergency room for the county. Our facility is nestled in the little 76104 zip code in the heart of Dallas Cowboy County, which is also known as Tarrant County here. JPS is licensed for 582 beds, and we have almost 177,000 hospital patient days per year. We are the 16th busiest emergency department in the country with almost 126,000 total ED visits every year and growing. We also have around 4,000 babies born each year, and we are a level 3 NICU and a level 4 maternal designated levels of care facility. We also have a huge push that we are doing here. When we talk about maternal sepsis, this is a really near and dear to my heart. I won't get into it, but it is a lot of the education that we have been doing this year. So we are designated by the ANCC with Pathways to Excellence. We promote excellence in our facility. We have the largest family medicine residency program. We are also certified in stroke, AMI, patient-led management, as well as sepsis. So for us, it's sepsis. We are the only Joint Commission disease-specific certified program in the nation that's a safety net county hospital. So as you can tell, we're really proud of our sepsis program here, proud of our hospital, all the accomplishments. But more importantly, I really hope this presentation allows you to look inside at the community that we serve and the education that we deliver. So with that, I'll turn it over to my partner, Alexis Wells.
Thank you so much. So thank you again for joining us as we share how we educate everyone at our organization. We're going to begin with what I consider to be the traditional education. We have the opportunity to get in front of our providers during their onboarding. So as mentioned previously, this is important because it lends the new providers the focus. So what we're looking at for sepsis and who they can contact when they have questions. The same philosophy applies to new nursing and provider residents because, as Jess had just mentioned, we are home to the largest hospital-based family medicine residency program. Being a part of their onboarding establishes a relationship early on, and if you only get a few minutes with them, ensure you leave your contact information because they will use it later in their career. Speaking of later on in their career, the next slide covers ongoing traditional education that takes place after orientation. This includes committee and department meetings, one-on-one education, and taking every opportunity possible to provide resources so it is easy to do the right thing every time. After establishing a sepsis program at your organization, if you have not done so already, you should be offering at least a monthly committee meeting with your champion stakeholders and program leaders, and they should be disseminating that information to their departments. This setting provides you the chance to discuss fallouts from best practice, which we call opportunities for improvement or OFIs. New tools or publications like the CDC's Hospital Sepsis Program Core Elements Assessment Tool, as well as working on streamlining processes on identifying and treating sepsis. One-on-one education is essential and cannot be overlooked. Sometimes key points can get lost in translation through email or text, and you can have a more meaningful and deeper discussion in person, especially when it comes to OFIs. Although nurses do need one-on-one education on OFIs as well, don't get me wrong, we also have taken this opportunity to teach our nurses how to talk to their patients about sepsis and post-sepsis syndrome. We have provided them with a resource to start that conversation about what is really happening with their patient and what to look out for after the patient goes home. Sepsis isn't a really bad infection or a bloodstream infection. It's sepsis. And our patients need to hear that term and understand what is going on with them. Without telling them they have sepsis, how will they learn about post-sepsis syndrome? Patients need to know how to care for themselves after recovering from acute insult from sepsis. And we believe so strongly in this that our perception of care and talking with the patients about post-sepsis syndrome is one of our Joint Commission metrics for certification. The sepsis RN at our organization, who works very closely with Jess, does rounds on patients diagnosed with sepsis and simply asks them, did your nurse or provider talk to you about the long-term outcomes of sepsis? If the answer is no, then the sepsis RN provides education to the patient right then and there. Through these discussions, we can identify barriers or struggles with providing care, and we can do something about it. At JPS, we've created multiple tools right within our electronic medical record, like smart phrases, smart lists, order sets, and best practice alerts, or BPAs, to help guide the providers and nurses taking care of a septic patient. We also hand out badge buddies during every encounter and post the sepsis algorithm at various stations to facilitate quick decision-making right at their fingertips. As we move away from traditional, it's important to keep in mind that we're not limited to only in-person education and that everyone learns differently. Providing a platform that allows self-paced learning, like through annual or elective computer-based learning modules, or CBLs, is another way to educate your staff on sepsis. A key point to keep in mind with this type of learning platform is that you should offer education tailored to their learning environment, since an educator is not going to be present during this learning. Jess has been working so hard on building an OB CBL and inpatient CBL so we can cover all major areas that might take care of a septic patient. Could we advance to the next slide, please? Thank you. Another avenue we can take is to offer virtual training or simulation. I offer this with a quick introduction to quality healthcare, which includes core measures like SEP 1. And then I launch a patient's room and I tell them to go have at it, just like the patient you see on your slide. And it lets the students point out the quality of care concerns, and I had little tidbits of information through the simulation. In this scenario, the patient was admitted for sepsis due to pneumonia, which allows me an opportunity to discuss what that means to take care of a septic patient. Another option that combines real-time self-paced education and resources is to provide a QR code, and we recommend putting this on a badge buddy. We have a QR code specifically for nurses and a QR code specifically for providers that takes them to a site full of algorithms, decision trees, and guidance like talking points that the staff member can quickly navigate through when they need it. Another virtual opportunity that we did not include in these slides, but is worth mentioning, is to present at Grand Rounds. Every month, we host multiple Grand Rounds based on the focus, so nursing or quality. And if you have this opportunity at your organization, we highly recommend taking advantage of this because you have the potential of reaching staff you may normally not get in front of, especially if you are a larger organization or a system of hospitals and clinics. Now, the next slide is my favorite part, which is learning through gameplay. Studies have shown that interactive and gameplay education can enhance the learning experience and increase knowledge obtained compared to a traditional lecture setting. We run our escape room with a live patient, meaning one of us actually plays the role of the patient, and the nurse has 20 minutes to save their patient from sepsis. We provide the staff members with a safe, controlled environment so mistakes can and will purposefully, because we do that, happen. So when they are in the real life environment, we hope it doesn't happen with the patient. We have received feedback time and time again that the nurses have gone from the nurses that have gone through our escape room, that they feel more confident in their skills of recognizing sepsis and to speak up to advocate for their patients thanks to this engagement. And I will pass it back to Jess.
Thank you, Alexis. Next slide, please. All right, so when we were building this presentation, the question came from others asking us, what is this term OFI? What does it stand for? So in our organization, we use the term OFI as it means opportunity for improvement, specifically with the SEP1 core measure. OFIs occur when there has been any kind of deviation from best practice. This is where our evidence is rooted, and we know those clinical practice guidelines are best practice. So once a deviation has been identified, what this means is that the bundle wasn't completed in its entirety, which means it could be a care issue, or it may be that there's documentation that isn't there. It's either lacking the support of everything that it needs to have within that chart, or we didn't document why we didn't do something. So that maybe the patient refused IV fluids, the patient refused blood cultures, whatever it may be. So we like to look at these from that perspective. And it's very important when we are discussing these gaps that we remember that we use the term OFI, or opportunity for improvement, and we do not use the word fallout, because oftentimes there can be a negative connotation that's associated with the word fallout. However, as we use OFI as an opportunity to learn and grow from that opportunity, we then work to improve our care for the next patient and the one after that. So OFIs are not punitive in nature. They're identified as an area where a gap has been identified. And as we know, every time you identify a gap, it leads to the PDSA cycle, and then it leads to better patient outcomes down the road. So this allows our team to review what we can do then as the sepsis team to support our providers and our nursing staff, such as Alexis talked about, getting doc phrases, building order sets, badge buddies. All of these are crucial elements to building your sepsis program. And through the use of OFIs, it allows us to be able to do this. So every OFI is sent to the entire care team. So this includes doctor, nurse, if a nurse practitioner or PA was on it. We want to make sure that everybody is put together as a team. And this really enhances everybody's ability to take something back from this case, because then when a doctor gets an email, they respond all, and the nurse gets to see their feedback as well. So it's really, really valuable. But every time an OFI is sent, like I said, it goes to the entire team. We want to encourage them to work together to bridge those gaps. And then we can provide that education, like I mentioned earlier. So as we are one team, we're doing great work, and everybody deserves that education provided the same way. Next slide.
So before an OFI is sent out to the entire care team, it first goes through the inter-rater reliability process. So for any OFI to happen, it first must arise from the care being provided. Although this slide says provider, it can be a nurse, it could be a phlebotomist, it could be a pharmacist, anyone at all involved in the care for the patient at the time the OFI occurred.
And then the sepsis team, either myself or my partner, Joe, that's my clinical sepsis nurse, we review those charts in real time. And then we know that a sepsis consult's been placed. These consults are derived from order sets. So these can be our physician order sets or even standing delegated nursing order sets. And then once we get consulted, Joe performs a real-time review of that chart, looking for any opportunities that are present in real time. And then what does he do? He reaches out to them through either like Epic message, Epic chat, but we're trying to correct that documentation while the patient is still in house. And that is really valuable to the program to have that real-time feedback given right away.
And we are also fortunate to have a CDI, or a clinical documentation integrity program, here at JPS. This department looks at patients concurrently while they are still in the hospital or shortly after discharge to ensure all pertinent conditions are documented to the highest accuracy with clinical evidence to support that condition. If there is a CDI specialist on the account, then they will review for clinical validity and will query the provider when sepsis becomes unclear, or if there's an opportunity to clarify specificity and or severity of the condition prior to it going to final coding.
And then we have our Step 1 abstractor, Amanda Lewis, another phenomenal member of our team. And I say team a lot as we're going through this because just as the program leader, I can't do it all on my own. I have a phenomenal team that I get to work with, and Amanda is one of those members. So she reviews 100% of the CMS Step 1 accounts that we have. We are really unique in that we do 100%. We do not do a sample with our Step 1. So it is really important to distinguish which ones were a sepsis consult, it was at real time, versus when they're in the hospital. When Amanda looks at these cases, it is very important to realize that these patients have been discharged, they've gone through the coding process, and now we really can't change the documentation. So we're looking at those as a gap and looking to see how we can fill that gap. So anytime that an OFI is identified, then it is left to myself or Joe to review those, and we review them, and I'm gonna let Alexis take the next one and go on there.
I got you, Jess. So after the OFI has been identified, so as Jess said, after coding, the account goes through another validation point where sepsis coordinator Jess reviews the account to see if she agrees with the OFI did indeed take place. If there is an opportunity to impact the OFI, maybe new documentation has presented itself or a different view highlights something that would exclude the account from the bundle requirement, the account is then sent back to Amanda in quality, and we all discuss. At this point, if there is an opportunity to clarify sepsis in the documentation, such as was it ruled out, or do we need a higher severity, or do we need the organ dysfunction, then CDI can send a query to the provider to get it clarified. We have found some OFIs occur because the provider didn't think the patient truly had sepsis, but due to poor documentation of this clinical decision, sepsis ultimately gets picked up and coded on the final bill. If the account did not have a CDI specialist assigned while in-house, we still have the opportunity during this process right here to send the account to CDI for review. If sepsis is removed from final coding due to the clarified documentation, the OFI is also removed. This allows us to have some validation of the Step 1 compliance rate. And I'll pass it back to Jess.
And so if after all of these steps that we have gone through, and it is very robust, the OFI remains to be valid, which means that the OFI will stand, then I send it out to that provider team, as I mentioned in the OFI slide. So I send the OFI out, I send a timeline with it, and then I request a response with feedback within 7 days of my initial email. It has in the email exactly what an OFI is. And then it has an attribution, which is very important because we're not placing blame. It's simply saying, my ED provider, this is attributed to you. And then I need you to respond within 7 days and tell me what we can do to support you to make sure that it doesn't happen again. Next slide. So this is probably one of my favorite slides, but as you can see, Step 1 compliance rate has so many impacts, including the CMS overall star rating, which is publicly reported. This way, the patient can look at the quality rating of the hospitals in which they're seeking care from. The Step 1 is also moving into value-based purchasing world, and knowing that we'll need to have, everybody will need to start upping their game with their sepsis program, which this webinar comes at an amazing time. So I am thrilled to share this graph with you. And so as you can see, the orange line is the national CMS Step 1, and it teeters right below 60%, followed by Texas, where JPS resides, which is in the red. And so that one is about 62 to 64% every year for the state of Texas. Now, the blue line, that's us. And yes, we are proud. But this shows that having this multidisciplinary committee and program really does help move the mark. And what we're hoping is that you can see that we have put a heavy emphasis on a team and on education. And by doing that, we're able to be above the state and national average. So with that, thank you so much for the opportunity to present on this.
I'm going to switch gears a little bit and talk specifically about education directed towards patients and their families. That is sort of a partner, a companion to education that's provided to providers and clinicians and staff. I'm going to describe work that we have done at Atrium Health. I have an adjunct appointment at Atrium Health and was there for several years. Atrium Health is a large integrated health system. The work that we did really focused on 10 hospitals in North Carolina, ranging from large urban academic centers to more smaller rural hospitals in North Carolina. So at Atrium Health, we recognized that sepsis patients not only needed focus on that early management period, that golden hour that Dr. Prescott mentioned, where antibiotics and other management needs to get in quickly, but also they experience persistent deficits and struggles even after that early period. And so we developed a program to help support patients in that recovery, a lot of it which is after discharge. We developed a program that we called the Sepsis Transition and Recovery Program, or the STAR program. And this was a institutional supported program that used a nurse navigator or nurse navigators to deliver best practice care for sepsis patients in that vulnerable period, right around the time of hospital discharge and for 90 days after discharge. This is a slide that it sort of shows a schematic of the activities that the STAR nurse navigators perform for patients. And I'll highlight the areas where education really pops up, which you'll kind of see is throughout the whole program. So nurse navigators will identify patients while they're still in the hospital and do some support and literacy assessments, health literacy assessments while they're in the hospital. In the preparation for hospital discharge, our navigators will provide sepsis education to patients and their families, kind of about what happened to them. Again, using the word sepsis, what is sepsis, and what they can expect after discharge. And then our sepsis nurse navigators will make phone calls to patients within 48 hours of discharge, and then again at regular intervals every few days for the first month and then every week for the rest of the 90-day period. And during those intervals, lots of bits of education are provided related to medication review, medication literacy, care coordination, and continued disease-specific education, what to expect, all of those types of things. And I'll get a little more specific about some of the tools we use for that later on. So just to share some outcomes of this program, kind of so that you know that what we're doing works, and we feel really proud of this. So we conducted a randomized controlled trial at 3 of the hospitals in North Carolina. We enrolled about 700 patients, and we compared patients who received support through the STAR program versus patients who received sort of the usual transition care support. And we found that patients who were supported with the STAR program had about 5% lower risk of readmission or mortality at 30 days compared to patients who did not receive support through the STAR program. And so that outcome was at 30 days. We also looked at a longer term outcome. Is this program having a kind of transformational impact on patients' clinical trajectory? So we looked at outcomes at 12 months and found that similarly, patients who received support with the STAR program had about a 7.5% lower risk of readmission or mortality at 12 months after discharge compared to sepsis patients who were just receiving usual care. So I'll dig in a little bit to the specifics related to education and what this program was providing. Just sort of a reminder, the STAR program was a multi-component delivery program that focused on lots of different things: symptom management, assessment of new deficits and treatment of new deficits, care coordination. But again, education was a really big one of those components. So this slide kind of highlighting the different time points that I mentioned in the other slide. Really, a guiding principle that we used to design the education component of the STAR program was that sepsis education is not kind of a one-off thing. It should be a kind of regular long-term process for patients to really understand exactly what sepsis is and what the expectations are. I mean, we take medical students and nursing students quite a long time to understand sepsis, and then we expect patients to get it all with one little document that they get at discharge, one piece of paper. And so that's just not realistic. And we realized that the education needed to come at multiple intervals at different bits when it made sense. And so the 3 different intervals kind of schematically represented here is we provide education right in that preparation for hospital discharge period where patients have lots of questions or family members have lots of questions. In the immediate post-acute, so right after they get discharged, and then in that extended post-acute where they have up to 90 days to continue to get support and continue to receive education about their sepsis event. And drilling down a little bit deeper into those specific areas at that preparation for hospital discharge period, really that's where we start with that disease-specific education, where we use the word sepsis. We make sure that the patient and the family know that they actually had sepsis. They didn't just have pneumonia or UTI, but they had sepsis, and then that carries the weight behind it in terms of what to expect and how seriously to take it, that I think Jessica had mentioned as well. Part of the education here is also reviewing the hospital course and making sure they understand what actually happened to them and what they can expect after discharge. And then the immediate post-acute period, so within 48 hours or a few days after discharge, patients are at home or in a new setting and they have lots and lots of questions and they need to sort of be re-educated. Again, reminded what sepsis is and why and what that means for them, but also re-educated in terms of what the medications they're on and why they're taking them, what follow-up appointments they have, and why it's important for them to follow them. Another thing that we found in some of our qualitative work is that sepsis patients are really worried about getting sepsis again. And so there's a lot of anxiety and stress related to not knowing how will I know if I have sepsis again. And so we do a lot of education around symptom monitoring. Here's what to look out for. Here's when to call for help, those type of things. And we provide education around kind of reset expectations that you may not have the same functional abilities as you did pre-sepsis. These are the things we're going to do to help you build back those skills up. But don't be surprised if some of these limitations are new. You're not alone in that. And then the extended post-acute, again, just because all of this is such a busy, complicated time for patients and their families, just continuing that. We were so lucky to be able to deliver this program for 90 days, that continued touch points where that kind of same information could be repeated and questions could be asked. In that long-term education period, we help them begin to transition to follow up with their PCP and making sure that everyone's on the same page as far as what happens, what's expected. And then at this time, we also provide education around the impact of sepsis on long-term mortality risk and long-term complication risks. And we use that as an opportunity to revisit their goals of care, to make sure that we do know really clearly what their goals are and what type of healthcare, what type of decisions they would want in the future. I'll just briefly touch on some of the specific tools that we do provide. So in that preparation for discharge, while patients are still in the hospital, we have them watch this Life After Sepsis video. It's sponsored by the Sepsis Alliance and the Society of Critical Care Medicine. It's available on YouTube. So we assign this to patients while they're in the hospital and have them watch it, preferably with their family member. This video kind of gives a really nice insight into what to expect after sepsis. We use the Life After Sepsis fact sheet that's available through the CDC. And some of you can go to the next slide. Some of the specific things that are addressed on this sheet. Again, what is sepsis? And I will say this about 10 times, and I think Jessica and Alexa said this too, is using the word sepsis is so critical. It's one of the things we hear from patients all the time. Nobody ever told me I had sepsis. What do you mean I have sepsis? And so it's so important to use that word and to make sure patients understand how serious it was and what the persistent risks are for them afterwards. This is still from the Life After Sepsis fact sheet. Some of the expectations, that's fine. Some of the expectations that people we can set for people. Again, people get home and they think, well, I just had pneumonia, I got antibiotics, I should be all better. And it can be a huge source of anxiety and stress and kind of alteration in social roles, all these different things that people can have. And so we try to educate them on what the expectations are, and particularly the sense that this is not just you. This is a really common thing that happens to people. A couple more things. This is a kind of education around care coordination, sort of how we say it. So, so much happening in that acute, post-acute period. Lots of appointments to get to, medications to take. Medications change, right? So you may have medications that you were sent on after the hospitalization that you're supposed to stop, and your home meds you're supposed to restart. So we try to give a lot of education and some structured forms for people to get that. Keep that organized. And then this is a stoplight tool that I had mentioned earlier that we give to help people monitor their symptoms and kind of get some guidance for when to seek help. This particular tool is from Sutter Health, but I think there's a variety of different options available out there. But we found that this both serves a practical purpose by truly telling patients when to call when they need help, but it also provides a lot of reassurance for patients where that uncertainty and that anxiety of how will I know if I have sepsis again? What will I do? It kind of gives that guidance that gives them a bit of a peace of mind that they know what to do. And so just to summarize all of that, some of the key points from our learnings and the work that we have done for post-sepsis patient and family education, really key that it's a dynamic process. The one-time sepsis information at discharge piece of paper really isn't going to cut it. This should be a dynamic process that's delivered multiple time points through the recovery. Again, use the word sepsis as much as you can for patients and their family, and also in communication with other care providers. So with the PCP or with other people that are caring for the patient, use the word sepsis so that it's very clear what the patient has been through and what to expect after discharge. And our education tools, the highlights of the things that we address, we summarize the hospitalization events. We provide education around medications, around their expectations and anticipatory guidance, best practices that they should be taking on for recovery, and again, a structured process for when to act and who to call if they start to experience new or worsening symptoms.